the fall, how it ends. It's the fall, how it ends. Or it's the fall, how we rise again. Ooh.
Greetings for the day. Today we are here with yet again another episode of PhysioTV. Today we have with us Dr. Janhavi Atre ma'am. She has done her master's in neurophysiotherapy from Vikhe Patil College of Physiotherapy, Ahmednagar. She has also done international certification for neurodynamic solutions for upper limb as well as lower limb. And she's also a certified PNF therapist level 1 and 2 from the International PNFA Association. We welcome you, ma'am.
Thank you so much for the kind introduction, Amrita. I would like to extend my warm gratitude and thank you for inviting me to deliver this talk on limb girdle muscular dystrophy. I would also like to thank Sancheti Institute of Orthopaedics and Rehab as well as Sancheti Institute College of Physiotherapy for giving me this opportunity to discuss my perspectives on limb girdle muscular dystrophy today. Thank you so much. May I continue with my presentation now?
Absolutely, ma'am.
Okay. I'm sharing my screen. Let me know if it is visible. Can you see it?
Yes.
Okay. So today we will be discussing physiotherapy management of limb girdle muscular dystrophy. In short, as you all know, muscular dystrophy is a very large term. It encompasses all different types of muscular dystrophies, and limb girdle muscular dystrophy is a small part of it, small yet important. So let's move on into the presentation. Today, I will be covering its introduction to muscular dystrophy, different types of muscular dystrophy, clinical presentations, and what all characteristics you get to see in limb girdle muscular dystrophy, impairments which are associated with limb girdle muscular dystrophy, its assessment and outcome measures which are specifically used in this condition, medical management, as well as physiotherapy management of limb girdle muscular dystrophy. So, as we know, muscular dystrophy is a very large term. It's a heterogeneous group of inherited disorders recognized by progressive degenerative muscle weakness and loss of muscle tissue. It usually starts in childhood. It's a muscle condition. It's a muscle degenerative condition. It affects strength and action of muscles. It can be generalized, so it can lead to affection to the entire musculature of your body, or it can be limited to certain muscle groups of your body. Skeletal muscle and other organs may involve in the later stages of life. As we all know, in case of Duchenne muscular dystrophy, which is also a type of dystrophy, you have cardiac muscle involvement later in the future. Because of muscle involvement, skeleton gets involved, and you have deformities like scoliosis and increase in lordosis happening in the later stages of life. The limitation of muscular dystrophy is basically difficulty in maintaining balance, walking, and difficulty in maintaining your posture, upright posture. Neurological, behavior, cardiac, and other functional limitations then follow uh, later in the disease as the disease progresses. There are different types of muscular dystrophy. These are a few types of muscular dystrophies. We have myotonic Duchenne muscular dystrophy, Becker's muscular dystrophy, limb girdle muscular dystrophy, facioscapulohumeral, congenital, oculopharyngeal, distal, and Emery-Dreifuss muscular dystrophy. Now, let's see the prevalence of it. Out of all, as we can see, Duchenne muscular dystrophy accounts to close about 23% of the total muscular dystrophies seen, followed by facioscapulohumeral dystrophy, myotonic dystrophy, which accounts for 13%, hereditary neuropathy, spinal muscular dystrophy accounts for close to 12%. Limb girdle muscular dystrophy, which is going to be a topic of discussion today, accounts for 10%, followed by congenital myopathy, and finally congenital muscular dystrophy, which accounts for total of 3% of total muscular dystrophies. Now, this is presentation of weakness in different types of dystrophy. As you can see here in this picture, in case of Duchenne and Becker muscular dystrophy, now Duchenne is a very severe kind of dystrophy, which also affects the child's lifespan. Becker's, on the other hand, is not that severe and is limited to it. It does not really affect the life expectancy of child. So mainly neck muscles, shoulder muscles, and upper limb muscles mainly are affected in case of Duchenne muscular dystrophy, whereas some part of hip musculature, entire part of hip musculature to be precise, the anterior aspect, the posterior aspect, so hip flexors, hip extensors, abductors, knee flexors, extensors, and ankle plantar flexors and dorsiflexors are affected in Duchenne and Becker types. In Emery-Dreifuss type, the affection is also mostly in the distal parts of the lower limb and proximal parts of the upper limb, where forearm, where proximal musculature, mainly pectoralis major, is affected, and uh, arm muscles are affected. In limb girdle type, as we are going to see limb girdle in detail, in limb girdle, mainly muscles that are affected are hip adductor muscles, hip flexor muscles, and in upper limb, mainly pectoralis major muscle, then pectoralis minor muscle, and all arm muscles in anterior and posterior aspect. In facioscapulohumeral type, we have fascia. So your facial muscles are mainly affected, followed by upper limb muscles, and some part of calf muscles are also affected, as we can see here. And in oculopharyngeal type, as name suggests, a person has difficulty mainly in swallowing and performing movements of face. He also has somewhat difficulty in phonation, and weakness or progresses to upper limb, proximal musculature of upper limb, and proximal musculature of lower limb as well. So coming to limb girdle muscular dystrophy, uh, Limb girdle muscular dystrophies are a group of hereditary myopathies characterized by predominantly proximal muscle weakness, that is pelvic and shoulder girdles. So mainly, usually we have affection which spans from your pectoralis major muscle and continues down. It usually does not affect your forearm muscles and your wrist muscles. So forearm and wrist is spared. And in case of lower limb, pelvic musculature, mainly your hip flexors, abductors, adductors, hamstrings, and quadriceps, that is, knee flexors and knee extensors, respectively, are affected. As well as the initial complaint that the person has in case of LGMD is difficulty in standing on toes. There is no pseudo hypertrophy of calf seen in LGMD, but patient has difficulty in standing on toes. So first presentation usually comes via your calf muscles and then it progresses upwards. LGMDs are now recognized as heterogeneous group of myopathies that vary in severity and may affect persons at all ages from childhood to adulthood. Usually, a child who ages from say 15 years to say close to 30 years is the age range in which limb girdle muscular dystrophy affects a person. Limb girdle muscular dystrophies are classified into two main groups depending upon their inheritance pattern. So there are basically two types. There is also a third type, which is called as X-linked dystrophy, but it is very rarely seen. The two dominant types of LGMD are limb girdle dystrophy 1 and limb girdle dystrophy 2. LGMD 1 is autosomal dominant, while LGMD 2 is autosomal recessive type. What do you see in LGMD? Characteristics of LGMD. Now, Walton and Natras were the two physicians who first proposed LGMD in nosological entity in 1954. The definition included following characteristics: either expression in male or female sex. So it was not usually only males or only females, as we see in case of DMD, that males are more affected or males are exclusively affected. Onset usually is in the late first or second decade of life, but also middle age. In some cases, rarely, people can get affected with LGMD in mid 40s or late 40s as well. Usually autosomal recessive and less frequently autosomal dominant. Involvement of shoulder or pelvic girdle muscles with variable rates of progression. Severe disability within 20 to 30 years. Say, for example, if a person shows first clinical signs of LGMD at say 18 or 19 years of age, then the disease will probably progress in 20 to 30 years. That is when he reaches to say 58 years of his life. There can be severe disability. Muscular pseudohypertrophy and or contractures are very uncommon, unlike in case of other forms of dystrophy where contractures are the main characteristics. LGMD will not show characteristics of contractures as such. What happens exactly in LGMD? What is the pathophysiology behind it? LGMDs basically result from mutations in genes encoding specific structural protein, prototypes of failure of the muscle fiber to maintain its physical structure during contraction, leading to sarcolemma breakdown and myofiber degeneration and necrosis. So there are specific genes in our body which encode specific structural protein in our muscle. This protein is also called as, in case of DMD, it will be called as dystrophin. In case of LGMD, this protein is called as dysferlin protein. So, because there is some genetic mutation leading to mutation in gene, as a result of that, the protein, this dysferlin protein, is not encoded properly, and that leads to difficulty in contraction of muscle. And because of difficulty in contraction, there is breakdown of the sarcolemma is the covering of the muscle fiber. So because the sarcolemma breaks down, myofiber degeneration occurs, which leads to necrosis meaning death of that particular tissue. So if there is necrosis to such an extent that every day some muscle fibers are say dying because of this sarcolemma breakdown, then there will come a point where muscle will not contract to its maximal force, and it because of sarcolemma breakdown, it will lead to maximal amount of atrophy in the muscles, affecting strength, and further because of strength, other things which come hand in hand with strength are also affected. The exact mechanism of the progression of this muscle fiber necrosis in muscular dystrophies is still unknown, as well as role of energy production and the cascade of events ending with muscle fiber degeneration is still unknown. We exactly don't know what exactly happens, but this is just a pathophysiology proposed. Uh, so as you can see in this picture, because of this genetic mutation, there is alteration in the mitochondria. Alteration of mitochondria will lead to abnormal muscle adaptation, and which will further lead to impaired muscle regeneration, sarcomere disorganization, sarcomere which usually aligns like this and is important for contraction and relaxation of muscle. We all know the sliding filament theory of the muscle contraction. So, because of disorganization of sarcomere, this sliding will not happen effectively, leading to more of oxidative damage inside the muscle, causing calcium dysregulation and further uh, causing damage to the muscle fiber and breaking the muscle fiber apart. Cardiac involvement, the first impairment seen in LGMD is the cardiac involvement. LGMD patients will not show you symptoms of chest pain or pedal edema or palpitations that precede cardiac myopathy and sudden cardiac death. But cardiac manifestation are identified only with cardiology testing. So, with your ECG testing, with your 2D echo testing, like your left ventricular ejection fraction may or may not get affected in cases of LGMD. In severe forms, cardiac involvement is seen in some cases, but usually cardiomyopathy and cardiac involvement is not a very clear clinical feature of LGMD. Detection and appropriate management of cardiac dysfunction are important to reduce mortality and morbidity. Patients with muscular dystrophy often have improved quality of life following appropriate pharmacological treatment, device placement, or surgical intervention for the cardiac involvement. So even if there is cardiac involvement to some extent, it can be corrected using pharmacological treatment or device placement. So those remedies are available, and patient responds beautifully to these remedies. Dysphagia and nutrition. Patients have difficulty in receiving adequate intake due to dysphagia or inability to feed themselves due to arm weakness. Usually, dysphagia is not seen that much in LGMD, but if upper limb weakness is extremely severe that the patient can't feed themselves, then nutrition may get affected. Maintaining adequate nutrition and body weight is important for optimizing strength, function, and quality of life, as we all know. Pulmonary complications, oropharyngeal or ventilatory muscle weakness, high risk of developing respiratory failure during course of the disease. If ventilatory muscles are affected, then and then you will have pulmonary complications associated with LGMD, or else usually cardiac and pulmonary complications are at the bottom end of the clinical features associated with limb girdle muscular dystrophy. Spinal deformities, musculoskeletal deformities such as scoliosis, as you can see here, scoliosis, kyphosis, and lordosis can result in discomfort and functional impairment interfering with gait, activities of daily living, and pulmonary function. This usually happens if physiotherapy is not started at the appropriate time. If you start physiotherapy late in the later stages where affection is severe that it can't be corrected whatsoever, then it leads to spinal deformities like scoliosis and kyphosis and increase in lumbar lordosis. So if proper stability is maintained between the agonist and antagonists of these muscles, of the muscles of our body, then usually spinal deformities can be prevented. Now, as we all know, LGMD has autosomal dominant and autosomal recessive type. There are specific impairments associated with these uh, autosomal dominant and recessive types. Now, LGMD2A, which is autosomal dominant, is most common form of LGMD, and 75% of its onset occurs in the age of 5 to 20 years. There is weakness in hip extensors, adductor, and knee flexor muscles. Scapular winging is a characteristic feature of LGMD2A type, which is autosomal dominant. Calf, you will see calf hypertrophy along with abdominal laxity and Achilles contractures. There is rare facial involvement. There is obviously increase in creatine kinase level, which is 500 to 20,000 units per liter. Lobulated fibers on biopsy, and diagnosis is usually confirmed by doing genetic testing or by doing a biopsy of a calf muscle of the patient. In LGMD2B, onset is usually late, occurs in 50 to 35 years of age. Legs are affected first. As I told you all, person has difficulty in standing on his toes. So basically, calf muscle weakness starts, and then that weakness progresses onto the proximal joints of the leg, that is the hip joint. So your hip flexors, abductors, adductors are affected. Some distal leg weakness is seen. Usually only calf muscles will be affected. There will be sparing of dorsiflexor muscles. But again, due to imbalance between agonist and antagonist, movement at the ankle is affected. Athletic prowess when young, yeah. So many of these patients will give you a history of, I was a very good athlete before I saw these clinical features in me. I used to play at state level. I used to play at district level. Any sport, it might be a sport like table tennis, lawn tennis, or badminton. These patients usually are athletes before. Uh, they have very good they before seeing this clinically, they have very good prowess in athletics. No facial weakness or dysphagia. LGMD will not show any facial weakness or dysphagia. There is no clinical or respiratory involvement also seen. As I said, no clinical cardiac involvement. Only if the severity of the condition progresses further will you see affection in the heart muscles and respiratory muscles. But overall, unlike for Duchenne muscular dystrophy, you won't see respiratory and cardiac involvement. Creatine kinase again elevated, just like in LGMD2A. Inflammation on biopsy is approximately 40%. Yeah, because of muscle fiber degeneration, because of damage to the sarcolemma, everything inside the muscle will ooze out, leading to inflammation. Now, this can be seen on the biopsy, and we usually we confirm our diagnosis using genetic testing. Now, how will you differentially diagnose limb girdle muscular dystrophies? Uh, they can be differentially diagnosed as dystrophinopathies, Bethlem myopathy, X-linked Emery-Dreifuss muscular dystrophy, myofibrillar myopathies, metabolic myopathies, inclusion body myopathies, Pompe disease, and FSHD, that is facioscapulohumeral dystrophy with facial sparing. So all these conditions can be misjudged with limb girdle muscular dystrophy. Laboratory diagnosis of limb girdle muscular dystrophy. Number one will be elevation in the serum creatine kinase level, which will be substantially elevated, as great as 200 times. When the person first checks for serum CK level, they are increased by many folds. EMG will frequently show small brief motor unit potentials with early recruitment Although long duration polyphasic motor units with decreased recruitment often pop up in weak calf muscles. So when you perform EMG of the calf muscle, you will usually see polyphasic, that is, a muscle contracts, but it will contract, relax multiple times, giving you many polyphasic motor unit potentials. Muscle biopsies may reveal dystrophic features, vacuoles, amyloid deposition, and endomysial and perivascular inflammatory infiltrates in more than 50% of the biopsies in some series. It's mostly presence of inflammatory infiltrates because everything from the muscle oozes out, leading to increase in edema. All of this can be seen as an inflammatory infiltrate. So your CD4 cells, which are responsible for immunity, are there, and macrophages can be seen in the muscle biopsy. This inflammation has been thought a secondary reaction to degeneration. Now, how will you assess LGMD? Assessment of LGMD is extremely important, as first you will notice this clinical features of uh, firstly, age of onset of weakness, a clinical feature of inability to stand on toes or inability to walk uphill can be one of the first clinical features by which you can suspect that it can be some part of dystrophy, some part of muscle dystrophy. Then the patient will give you a history of not able to walk uphill. He will also tell you that my walking has changed since the recent past. I'm walking with difficulty. Patient usually comes to you with waddling kind of gait. He will have difficulty in clearing off his ankle and knees because of reduced activity in his calf muscles and also hamstrings and quadriceps. Patient status before assessing is extremely important. Is he bedridden? Is he sitting, or is he standing, or is he able to walk? Patient's functional status is extremely essential before assessing the patient entirely. So depending upon what the functional level of the patient is, what is the age of the patient, and what is the severity of the condition, and all the investigations which come along with the diagnosis will have to be taken into consideration for management of limb girdle muscular dystrophy. So, what all things do we need to assess? Number one is range of motion and strength, especially in proximal shoulder, that is your pectoral girdle and pelvic girdle muscles. A patient who has an ambulatory status, who is walking with an assistive device, or who is walking without assistive device, walking independently, will obviously have a strength of grade 2 and more in his lower extremities, but that still has to be assessed properly with manual muscle testing and individual muscle testing. A range of motion has to be assessed. Outcome measures of muscle functions. I will talk about outcome measures as we progress. Outcome measures which are specifically validated for limb girdle muscular dystrophy have to be filled, and a follow up after every 6 months has to be kept to know the improvement and progression in the rehab as well as in the functional status of the patient. Then, along with range of motion and strength, balance, gait, cardiological assessment, as well as respiratory assessment. So, if a person is ambulatory, cardiological assessment in the form of stress test can be given, can be done to the on the patient. So basically, a therapist will refer the patient to cardiologist. As long as respiratory assessment is concerned, spirometry assessment is the gold standard for respiratory assessment in LGMD. Along with spirometry, chest expansion and chest excursion need to be assessed in regular intervals of time. And along with that, proper referral to a chest physician if the patient is suffering with respiratory muscle weakness, which is causing affection in the tidal volume of the patient, or if the patient has started to complain of any palpitations while walking, then definitely it's a time to refer a patient to a respiratory physician. What are the outcome measures? These outcome measures are specifically validated for limb girdle muscular dystrophy. One of it is North Star Ambulatory Assessment. This is a beautiful scale which is used for assessing ambulation of the patient of LGMD. 6-minute walk test usually assesses the endurance of the patient. Performance of the upper limb tool when upper limb muscles are affected. Performance of the upper limb tool is one of the most reliable measures of assessment. Motor functional measurement scale and Berg balance scale. If balance is affected, in case of balance issues, Berg balance scale is also validated in case of limb girdle muscular dystrophy. Medical management. Now, medical management usually says gene transfer, myoblast transplantation, neutralizing antibody to myostatin, and growth hormone. All these, uh, all these management techniques or procedures are in a very nascent stage and have not been fully proven yet. So they are in a very developing stage, kind of stage, and medical management is only present for pain if the patient is having pain in the muscle due to degenerative changes and is cramping, or is having pain, then there is only symptomatic management available using corticosteroids and non-steroidal anti-inflammatory drugs. That's the only management present. Other than that, all the other medical management aspects are in developing stage as yet. Now let's move on to physiotherapy management. Since we have seen what all impairments are there in limb girdle muscular dystrophy, so to list the impairments quickly, basically weakness. First thing is weakness in proximal hip muscles and proximal shoulder muscles. Weakness usually progresses to knees from the hip, and usually progresses from knees to the hip, and sometimes calf muscles can be affected. So depending upon the age at which the disease onset is there, you will get different stages of progression of the condition and different severity of the condition. So if the patient is ambulatory, what all management can be done. If the patient is bedridden, what all management can be done, we will see. Goals of physiotherapy management: number one is patient education and counseling. It is extremely important to counsel the patient to maintain muscle strength, to prevent secondary complications, deformities, and contractures, to correct and maintain posture, to maintain functional level of the patient, maintenance of respiratory function, gait training, improve endurance of the patient, and promote and maintain activities of daily living of the patient. Why is patient education and counseling very important? If the patient does not know the progression of the disease, he or she will not take those steps in rehabilitating himself and getting ready to face any outcomes that the disease presents itself with in the future. So that is why it is extremely important that you educate the patient as well as caregivers of the patient, the family members of the patient, about the disease and the outcomes which are associated with the disease, and so that they prepare themselves to cope up with any complications that come with the disease in the future. To prevent and counteract the progression of contractures, retractions, and deformities. So basically, as your hip muscles and knee muscles are affected more in lower limb as compared to upper limb in case of LGMD, stretching is one of the most sought out and effective techniques of preventing contractures and deformities. Stretching can be done in active ways, that meaning that the patient himself will perform the stretching, or manual stretching. Manual stretching can be done by therapist Manual stretching is also called as passive stretching. Stretching can be self-managed or rehabilitative. That is, if it is self-managed, it is given by caregiver, or when it is rehabilitative, it is given by the therapist. What should be the frequency and duration of the stretch? Both in ambulant and non-ambulant patient, stretching of muscles and structures at risk of tightness in the different forms should be performed not less than 4 to 6 times a week. So if you're giving rehab to the patient in a 30-minute setup, one muscle should not be done. Uh, one muscle has to be stretched for one time only. So you should not perform stretching more than 4 to 6 times a week, because again, with increased amount of stretching, there are chances that you may cause damage to the muscle fiber because of elongation, and further the muscle further reaches early in that plastic stage, and further the muscle fibers have a chance of breaking. So to prevent that, stretching also has to be performed in case of ambulatory as well as non-ambulatory patients, but it should not be more than 4 to 6 times a week for each muscle group. It is only if only self-managed stretching is performed, extreme supervision has to be practiced, and patient should show the stretching to the therapist if he or she is doing it properly or not, if he's doing it at home. And once a month he has to keep a follow up with the therapist, because conditions like this will progress very quickly if exercise is not done. So it is extremely essential that a therapist and patient have a good rapport with each other. In non-ambulant patients, stretching should only be performed for mild contractures, that is joint tightness with preserved range of motion, or medium contracture, that is joint tightness with impaired range of motion. It should not be performed in case of fixed contractures. The use of orthosis can be integrated with but cannot substitute stretching. Obviously, if there are contractures, if in the assessment you find out that there is tightness of certain structures, and if not intervened in the right time, it can further lead to contracture. Some assistive devices have to be given to the patient along with stretching, but assistive device will not substitute stretching. Assistive device will only aid you in stretching. Stretching still will have to be performed by the therapist or by the patient himself for maintaining the extensibility of the muscles. Muscle power function and muscle endurance function. As you all know, muscle endurance will further be affected, because if muscle fibers are disintegrating day by day, muscles will be atrophied, and because of atrophy, there will be reduction in the endurance of the muscle. So a patient will have difficulty in walking for a longer period if he's ambulatory. And if he's not ambulatory, then because of immobility, there will be further affection in the endurance of the patient. So, what is the role of physiotherapist when patient is ambulatory and patient is non-ambulatory? In case of non-ambulatory patient, you have to preserve that strength of the muscle. Whatever strength is available, or whatever strength is present in that muscle, you still have to maintain it and preserve it by doing some or the other form of exercises. The goals are to prevent no use atrophy, that is non-use atrophy, to maintain and optimize the residual muscle strength, to support and optimize efficiency and energy conservation, and also containing stasis edema. All these goals will be ticked if a person concentrates, if the therapist concentrates more on giving rehabilitation in the form of active, more of engaging the patient into active exercises, and thereby improving muscle endurance and improving and maintaining the muscle endurance. What is the progression of therapeutic exercise, and what's the frequency of therapeutic exercises that need to be practiced in case of LGMD patients? Therapeutic exercises should be defined by the following components: frequency, intensity, time, and type. As we all know, the FIT principle. Both non-structured and structured activities and sports can include the two main exercise types, that is aerobic and cardiovascular fitness training designed to improve cardiorespiratory endurance, and strength resistance training, which is performed to improve muscle strength and endurance. The latter can consist of concentric, isometric, or eccentric contractions. Now, there are two types of activities that we can give to the patient. Number one is structured activity, and number two is non-structured activity. Structured activity is the activity given to a patient in a view of achieving some goal or achieving uh, some sport. Say, for example, if a person is playing some sports and patient has to achieve that with lesser assistance, if that has to be achieved by the patient, then you will have to give a non-structured exercise. So exercise only in form of play can be given to the patient. But if a structured exercise program is given to the patient, structured exercise program will be a supervised exercise program, which will involve the therapist. And therapist will, according to the assessment, the therapist will prepare a customized treatment program for the patient, which will incorporate both the components, cardiovascular and fitness training component, as well as strength or resistance training component. Cardiovascular training component will be to improve the endurance of the patient, which will include any activities, but the activities which are in the clinical practice guidelines for LGMD are basically two activities. One is stationary cycling, and number two activity is swimming. So these two activities are extremely beneficial in case of LGMD for maintaining and to some extent improving their cardiorespiratory endurance. While strength and resistance training has to be very customized and specific to what patient demands. If the strength of the patient is grade 2, you have to incorporate resistance training in grade 2 and make sure that the strength is progressing from grade 2 to grade 3, and give different positions to the patient in gravity eliminated, anti-gravity, incorporate Swiss ball training to the patient so that you can incorporate engage core of the patient, give activities in anti-gravity and gravity eliminating planes to improve muscle strength. Newest clinical guidelines in LGMD say that eccentric exercises are not so beneficial for patients with LGMD. What comes in eccentric exercises now? Eccentric exercises are basically lengthening kind of exercises where there is increase in force in the muscle as a result of lengthening of a particular muscle. So, already in case of limb girdle muscular dystrophy, there are chances of increase in progression of the condition because muscle will go into excess fatigue if exercise is continued for a larger or longer duration. So, to prevent that, eccentric exercises are basically avoided because eccentric exercises can further accentuate or accelerate increase in breakdown of the muscle tissue, thereby causing more necrosis. That is why more of concentric and isometric exercises are basically planned for limb girdle muscular dystrophy patients. So, all open chain exercises will constitute concentric training program, and isometric, that is incorporating holds in particular position, can improve the ability of the muscle to sustain a particular contraction for a prolonged period of time. So that can be used. Also, PNF technique of stabilizing reversals and dynamic reversals is extremely beneficial in case of LGMD techniques. I personally practice stabilizing reversals and dynamic reversals. I also practice hold relax and contract relax in these patients, and it has proven extremely beneficial in case of LGMD. So more of concentration should be on isometric muscle training, followed by concentric. Eccentric training like squats, lunges, etc., should be avoided or should be prevented while giving rehab to these patients. Exercise recommendations. Now, how much exercise to be performed? Eccentric exercises, as I told you, must be avoided, whereas concentric submaximal resistance exercises, which cause muscle activation, can be incorporated, and moderate aerobic training is recommended. Aerobic training in the form of swimming and stationary cycling is the best in these patients. Balance training should be included in case of difficulty in maintaining sitting and standing balance. Uh, so balance deficits will basically be seen if sitting balance will be affected if trunk musculature is affected, which is rarely seen. Patients will definitely have balance issues if there is weakness in lower limb muscles in standing. So if you train strength, then also you will specifically have to train the patient for balance, because uh, balance will be affected as strength is affected. Patients can be evaluated by means of specific functional balance tests such as Berg balance test, gait analysis, and by recording the number of falls, which can indicate a balance impairment. A person with LGMD will usually tell you that in the last 2 or 3 months, I have fallen for like 6 to 7 times. It's difficult for me to stand erect, and while walking, I also don't understand. I lose my balance immediately. So, in that case, you have an idea that the main goal of the patient is to walk without falling. So your rehab regimen, your rehab protocol will have to incorporate activities which will not only train the strength of the patient but also balance of the patient. And mean frequency of exercises is at least 3 times a week for at least 30 minutes per session. Exercising for prolonged periods of time is not at all beneficial for these patients because exercising a lot will induce fatigue in these patients, and this fatigue persists for a prolonged duration. This fatigue does not subside easily because of a loss of muscle fibers, and if the fatigue does not go quickly, person will have absolute difficulty in performing his activities. We don't have to tire patients out by giving excessive training to the patients. Exercises have to be at a submaximal rate according to the patient's capacity. We have to give breaks after we perform one set of exercise. We have to give a break of 10 to 20 seconds and then progress to another set of exercise. And usually exercise recommendations are only 3 times per week, not more than that. Always consider patient-specific conditions, including compliance and any relational issues, and avoid unnecessary clinical interventions, which could have a negative impact on your activities of daily living. Always concentrate on the functional needs of the patient. What is that the patient is wanting from a physio or a rehab professional? If he's saying that my balance is the main issue, please make sure that you concentrate more on balance. Incorporate strength training, incorporate balance in different activities so that these activities are further going to be useful, as it will lead to transfer of training in activities of daily living that the patient has to perform in his daily life. How will you train for balance? Dynamic balance is mainly affected, as I said, due to weakness of lower limb muscles. Training standing balance by use of narrow base of support. Always go from wider base to narrower base of support. Training different strategies, ankle strategies, hip strategies, stepping strategies to prevent falls. Basically, patient is also asked to maintain a diary of falls where he or she records his fall every time he falls, and we can also monitor based on falls if the rehab is going right. So if the rehab is going right, we already know that the falling frequency of the patient will go down. Training the patient by using different strategies like hip strategies, ankle strategies, stepping strategies will be extremely beneficial, because then the patient is taught how to manage himself if he ever comes down to falling. So they are educated beforehand if they are to experience a fall, how to manage themselves without getting injured. Gait training, supported ambulation involving use of assistive devices of different types, such as bodyweight supported treadmill training and robotic assisted training, is beneficial. The research is still in progress about the effectiveness of this, but some studies definitely say that bodyweight supported treadmill training and robotic assisted training is beneficial for these patients in improving gait. LGMD patients basically have a waddling kind of gait. They walk with waddles because of basic weakness in hip abductor muscles and hip adductor muscles, as well as gluteus maximus muscles. And they also have difficulty in clearing their knees because of hamstring and quadriceps weakness. That is why they tend to waddle. So our aim in gait training is by improving strength of hip abductor and adductor muscles, followed by increasing strength in hip extensor muscles. We improve the walking, we improve the clearance of the patient and try to get down the spatial and temporal parameters of gait in line with the normal parameters. Use of assistive devices, mainly assistive devices can be given to the patient. The main goal of assistive devices is to optimize movement skills, manual skills, and postural changes and transfers. Functional orthosis should be considered to improve mobility and autonomy. Training for walking safety, including balance exercises, is suggested for as long as possible. Training for safe postural changes and transfers is essential. Appropriate manual or powered electric wheelchair prescription and customization is essential. Use of posterior support to calf, ankle foot orthosis, knee ankle foot orthosis, etc., for continual mobility. So if a person has difficulty in really clearing off and you find that there's contracture developing in the calf muscle, then AFOs can be prescribed for the patient. We are obviously not going to overburden the patient with that extra weight of the orthosis. We are going to prescribe it only when it is mandatory and only when it is essential to the patient. If you assess and feel that there is lesser support getting from the calf muscles for ambulation, you can give a posterior support to the calf muscles by giving posterior splint to the calf. Also, in later stages where ambulation is affected, when the patient is bedbound, in that stages, electric wheelchair prescription proves extremely essential to the patient. And also training the patient for transfers using these assistive devices. So assistive devices can be any. It can be a cane, it can be a quadruped, it can be a walker or anything. So training the patients for safe transfers using these assistive devices is one of the extremely important measures for rehab process. Finally, improvement in quality of life in LGMD. The main goal of rehab, as we all know, is improving quality of life of the patient. Anything we do for the patient is for improving his or her quality of life, making their life easier, making their life less difficult. Promote sport to improve participation. As I told you at the starting of the presentation, that usually athletes who are elite athletes playing at different levels of sport are usually affected. So we have to make sure that even if in sitting position they are able to practice that sport. We have to maintain that functional level in the patient. Include transfer aids and adaptive equipment to ensure the highest possible degrees of independence and safety. Transferring from bed to chair, chair to bed, car to chair, car to bed, car to car to elevator, say for example, all of this has to be taught to the patient. Assistive technologies, example, ergonomic support, robotic manipulators, home automation, environmental control, etc. should be considered in order to control autonomy. These appliances come into play when the disease has progressed to such an extent that the patient is completely bedbound. But before that, if the patient comes to you in early stages of the disease, you have uh, a lot of avenues for giving rehab to the patient. A customized rehab protocol is going to prove extremely beneficial. The main goal is not regressing the condition of the patient, maintaining the condition as it is and trying to improve it from that level further. What is the take home message from this presentation? LGMD is a group of inherited disorders characterized by proximal muscle weakness. It usually affects childhood as well as adulthood. Maximal affection is after 15 years of age to 30 years of age. Muscle degeneration is seen depending upon age of onset and severity of disease progression. Maintenance of functional activity and ADLs is of primary concern to physiotherapists. Medical management is at nascent stage and yet to be established. Quality of life of an LGMD patient can be maintained and improved using therapeutic exercises. Thank you so much. These are my references. Thank you for giving me this opportunity. May I now hand over to Amrita? Thank you so much for having me. That's
Thanks,
about it.
ma'am. It was a wonderful session, very
Thank you.
informative. I'm sure our viewers will take into consideration all the points that you have put forth for LGMD. It is a very rare condition, and we actually don't get to see a lot of patients. But if we do, we now know what we are supposed to do with the rehab, how we are supposed to go forward with the rehab. I'm so glad we invited you over for this talk.
Thank
And
you.
we got lots of information, and we're very glad for it. Thank you so much, ma'am.
Thank you so much for having me.
I would also like to thank Dr. Parag Sancheti sir, who is the chairman of Sancheti Group, and Mrs. Manisha Sangvi ma'am, who is the chairperson of Sancheti Healthcare Academy, for their constant guidance and support. Our principal, Dr. Apurva Shimpi sir, and our technical team. Without them, all of the sessions are not possible, as well as our loyal viewers, without which Physio TV won't be where it is today. Thank you so much.